So, what I would do today is I'll actually walk through a story in 3 parts. The first part is we want to say how we, used artificial intelligence to, arm our diagnostic strategies with more power. Second, focusing on how do we personalize care for our patients using evidence at its best possible way. And the third is how do we improve quality of care? What we know works does not get used properly enough. How do we make sure people get the treatments they need? A majority of our patients, especially those with structural heart diseases, are often in our community, going about their lives not knowing that they have any disease. And for many of the diseases, there are actually established class 1 therapies where their life trajectory would be meaningfully altered if they were on treatments. However, what ends up happening is even though if they do interact with the health system, it is from low touch contact points. They will do, low risk testing is done in a majority of people, but the testing that is truly diagnostic is done in a minority of people. Such that, a minority of people end up getting diagnosed and treated when they're not symptomatic. And it's pretty common for you to see these statistics, and the numbers vary by disease, but only 1 in 5 people are diagnosed before the onset of symptoms if they have structural heart disorders. But I think the role of AI-based even ECG diagnostic doesn't sort of end with clinical ECGs. Because who is the person who's getting a clinical ECG? They're not representative of the general population. And so we thought about, let's extend it to tools that are actually more accessible. And while you may argue, and I would agree with you, that the picture on the left is a marker of privilege and probably is not a person who's not able to get a clinical diagnostic test. But the tool on the right actually is not that way. It's something you can pass around. You can actually put it in any community place that you feel has the highest risk population and actually get 1 lead ECGs, up to 6 leads of ECG directly on the spot. So I think there is 30-second acquisitions of 1 lead ECGs at wherever the person lives is a very powerful strategy. But all we can do right now is pick up a fib. And then the idea is like, LV dysfunction is fairly prevalent. So, it's still 3% of the population has asymptomatic LV dysfunction. How do you go to other things? How you do HCM, amyloid, and other things that are very less prevalent? Because whatever you do, you're going to have a lot of false positives. So our thought was maybe we don't need a tool that does diagnostic grade stuff for each thing, especially in this setting. You need something that just gets people to the echo lab, that just gets people from where they are to where they need to be. So we built this tool which specifically takes these noising strategy that I just showed you, but doesn't try to detect LV dysfunction, but a composite of LV, some sort of malignant LVH, some form of severe left-sided valvular heart disease combined with LV dysfunction. And this common tool together actually is able to predict identify LV systolic dysfunction with a very high performance as well, just on a 1 lead ECG. And again, the performance characteristics are good enough that you would only get 1 in 2 false positives, which makes that if you were doing for a condition that's prevalent at about 8%, instead of doing 100 tests, you'll be doing 16. So, and I think it changes the game on how we can deploy these strategies at scale. So in the study that we published in the European Heart Journal last year, we built a new strategy that first teaches a model to read an ultrasound, cardiac ultrasound, without telling it what it is learning for. So the task was just telling the ultrasound machine to know about the models to know which frame comes after which. And that process trains the model to know that they're looking at the heart. And then with small amounts of label data, with about 10,000, with 10% aortic stenosis in a 10,000 sample, we're able to train really robust models that, in an external site, which is hospital, is not part of our Yale New Haven Hospital, we're able to show a performance, discrimination of 95% nearly. And it's actually pretty remarkable. It's actually, the plot on the bottom is actually the model prediction for people with no AS, with non-severe AS and severe AS, and the predictions are, grow over time, suggested that we're picking up patterns. Even though we only train on the binary flag of severe AS or not, the prediction is actually 4 signatures of disease. And we are able to sort of do temporally different cohorts, like we did only 2021 data, still showing remarkable performance. If anything, we're showing great generalizability. And then finally, we went to Cedars-Sinai. So we do a lot of this where we send models over. We don't ask for data. We send models over. Again, very similar performance, completely new population, able to pick up severe aortic stenosis directly from a single parasternal long axis video. So we built 3 sets of tools, all published now and available again on our lab webpage. You can pick who should undergo stress test versus CTA from the null promise trial, which we validated in the external Scott Hart trial. We took Canvas and Canvas R trials, used Canvas to identify who benefits from SGLT2 inhibitors on the MACE outcomes, and again, validated in the Canvas R trial. And third, we took patients in SPRINT, and we identified who benefited from intensive blood pressure lowering. And in the null accord trial, we were able to identify clearly that the SPRINT pattern of treatment responsiveness carries over in the null accord trial as well. Again, all of these tools are available for, and we're trying to do prospective studies to validate a lot of them. And then I think, our big push here is like using these things to scale up for quality measurement. So, the prior traditional experiences, we have no reliable indicators of processes. Historical perspectives guide current care because claims from last year tell us what we're doing today. There is potential to game because overcoding and undercoding can change drastically what we do. And it's dissociated from quality improvement. You got to figure out your quality improvement strategy separate from what your measures are. So our goal is to make process-focused measures, make them at the point of care, safeguard them against gaming, and align them with the QI incentives and QI initiatives